Ductal carcinoma in situ, or DCIS as it's more commonly known, makes up about 25% of all breast cancers. And it creates a real problem for women who come up with this diagnosis, because only 1 to 2% at the most of these cancers will kill you. So the mortality rate is only 1 to 1.5 to 2%. About 15% of people who do have ductal carcinoma in situ and they have it locally removed, there will be a recurrence rate of about 15% of those people, and that usually doesn't cause major problems. So the question is who should be treated and who shouldn't? How aggressive should we be when we're managing this disease? Now, to the delight of the industry, the medical industry, the mammography industry and big pharma, it's a big business to have women who 98 to 99% of the time don't need treatment but are going to get it anyway. They wind up with surgery, chemotherapy, and radiation most of the time because it's terrifying to hear that you have cancer and that even though you're in a very good position to survive from it, that it's still there and you want to get rid of it at all costs. A lot of people feel it's better not to do the tests to find ductal carcinoma in situ, particularly in women under the age of 50. And there's a lot of literature that's been published on that in the mainstream that says we should not be doing mammography under age 50, and it's creating problems for us to decide what's the right thing to do. Now, the rest of the world is convinced that that's not the situation, and we wind up being the only country in the world that does mammograms in women under that age. If we do, this is the consequence we're going to pay. Now, can you differentiate a ductal carcinoma in situ that's not a cancer, actually, and isn't going to bother you from one that is? The answer is it's pretty tricky. There's no solid data to be sure. The mammogram doesn't tell you. The ultrasound doesn't tell you. An MRI isn't going to tell you. It is possible that breast thermography could, and the reason for that is because the mammogram, MRI, and ultrasound are tests of anatomy. They're looking at differences in tissue density to see if there's a difference between the cancer and the surrounding tissues. It's much like flying over the North Pole in an airplane and looking to see if you can find a polar bear in all that ice. And it's just about that difficult. But we're so sophisticated in our technology that a lot of the times we can actually do it. Now, the breast thermogram or a breast mammogram is a test that a breast thermogram is different because it's a test that looks for the physiology of what's happening in the breast. There we're looking at how much heat is in that tumor, how much new blood vessel growth, how much neoangiogenesis is actually present in that breast. And the mammotherm shows us that. So it becomes a test that shows you the function of what's going on. And I have the suspicion, and many other researchers in this field also do, that that will differentiate between those DCIS tumors that are cancer from those that are just static and not going to cause any problems. So the real problem with this whole DCIS problem is that overdiagnosis is the big issue. We have far too many surgeries done, too many biopsies. The medical industry, of course, loves it. And there are a lot of emotional factors that go on with knowing that you're going to have a breast biopsy because you might have cancer. Another thing that's poorly understood and not really widely appreciated is that cancers spontaneously disappear at times, and a lot more often than you'd think. If you do biopsies, total biopsies of the breast and autopsies of women age 50 who have died from unrelated causes, you'll find that 30% of those women have a breast cancer. What's going on? We know that 30% of women age 50 don't die from breast cancer. They must be disappearing. Another study that was done by the radiologists on 100,000 women who they did mammograms on at the baseline at year 3 and year 5 of a study that did mammography over 5 years, found that there were about 2,000 cancers in that group. In another group of 100,000 women who have only had a mammogram done at year 5, they've only found 1,500 breast cancers. What happened to the other 500? It leaves you in a place where we begin to appreciate that we really don't know which cancers, which ones that we find are ones that are significant and which ones are going to disappear. We need better screening tests. There is no test in medicine that's 100% or even close. And we need to individualize the tests that we have so that we're using certain ones in the right setting for certain women. Under age 50, we know the mammograms shouldn't be done. And basically, we should only be doing breast thermography because it's safe, non-invasive, doesn't cause cancer like the mammogram can as well, and is fairly accurate. We know that women we suspect have the BRCA gene defect absolutely should never have radiation of any kind, not even a chest x-ray, let alone a mammogram. Why? Because we've tracked this in the mainstream literature and found that in women under the age of 20 who have had one chest x-ray, who had the BRCA gene defect, that the risk to get the breast cancer went up 250%. So this is kind of a complicated subject. This is something actually you can track over time. If you go to the section of the website that gives you your individual web page, you can track some of the lifestyle factors that are important that can help you prevent getting cancer in the first place, and you can track those findings that are not to your advantage and see how things are going. So we need to take as much responsibility as we can to follow ourselves to not get this disease in the first place, because once you get it, it's going to be a challenge that doesn't have a perfect answer.